Yeah, stenting is on the back end for us. I really try to avoid
Yep.
doing stenting in the common femoral. Common femoral for me is what we use for our cardiology work most of the time with impellers and TAVR and all the other stuff. I'm gonna share a few cases, and I would love to hear from you your approach, consideration, and I think it'll be fun to look at. I have three different cases. We'll start. We'll see how much time we have.
Okay.
Perfect. Let me just share the slides here. All right. Can you see this?
Yeah.
All right. So we're going to move on to review some cases and see what Nick can show us, what approaches, what's consideration, how he look at this when he sees this patient in the clinic, and how would he recommend approaching this. This is a 65-year-old female with history of pelvic radiation for uterus cancer. She came with a claudication Rutherford 3, and she had an abnormal ABI and followed by CT that showed bilateral severe common femoral artery stenosis. She lived in a different state, and at that time she was offered gold standard therapy, which is the right common femoral artery endarterectomy. And unfortunately, as you just mentioned, Nick, she ended up having side infection and lymphedema. Required IV antibiotic for 6 months, a wound drain, and all other therapy. She moved to Dallas, and but just going to show this. I think you commented about this briefly. I think this is an important paper to look at. It published in 2015, and it shows similar to what you discussed. It's not zero risk procedures for all comers. There is mortality, there is wound, there is return to wound
Yeah.
dehiscence, even though it's not high, but those are the disastrous case. So she come in and she said, my left leg hurts and I need therapy, but can we not do surgery? So that's coming in with that mindset. So we go in with an angiogram, and I mean, this is just bad. This
Yeah.
is
This is bad. I mean, this
that's
is.
like class 3, common femoral, profunda, SFA, everything is involved. So what do you think about this patient? Previous complication from the other side? If you're going to do surgery, what other technique you try to achieve in this patient to minimize the risk that she had before?
Yeah. So I mean, this is a tough situation. Of course, she already has a bad previous experience, which is quite unfortunate. Radiation can make things more challenging when it comes to surgery, of course, and the fibrotic tissue and the scarring. Of course, they try to avoid the groins, but you never know sometimes the field of view how that works. I can tell you though, looking at this again, outside of her really not wanting to have surgery, to me, with the bifurcation disease and involvement of the proximal profunda, we would generally at least consider doing this open. If she absolutely was against that, actually, from the cardiology literature, this would probably involve some bifurcation buddy wire technique into the profunda and SFA protecting these. But my biggest concern here is not the endarterectomy, or sorry, not managing or treating the disease. My concern here is damaging the profunda, because that would make this problem a way bigger problem. And because of that proximal ostial profundal calcification, we would prefer to do this via open endarterectomy.
Yeah, and my understanding from the colleague I'm working with when we review cases, this is, by the way, was not part of our study because she will be excluded for many, many reasons. And one of the things is that you can infuse some antibiotics solution to the site if you're worried about infection, and the way surgery is done. Also, the other consideration on this lady is she had surgery on the right side with complications. So if you're going to do an endovascular therapy, you really want to avoid accessing the right common femoral artery. So I'll tell you, we went a little bit, maybe this is, my passion. You've heard it a million times in many talks.
You're gonna tell me that you came retrograde in the SFA and you came retrograde in you did direct profunda stick and you came retrograde. That's what you're
No,
gonna tell
I made it more simpler. I went radial.
Oh, okay, radial. Okay, fine.
So what you mentioned, I think, is extremely important. I think we, in our fellowship, our endovascular fellowship and vascular surgery fellowship, we keep repeating over and over what you just mentioned at the beginning of this conversation. Most important artery is the profunda. You gotta protect the profunda. You cannot tell me common femoral to SFA and the profunda shut down. So what you said, yeah, went radial. We used a 119 radial to peripheral sheet, 6 French. We put two
Yeah.
wires. Luckily, actually, we were able to wire the profunda easily. And what we performed is we did an M5 plus 6 millimeter, I think 6 millimeter, if I'm not mistaken, 5 or 6 millimeter based on the IVUS. IVUS was done before, and we finished it for the so both IVL, both profunda and common femoral to SFA, and I used a serration balloon for the profunda
Yeah.
as well. I think that technology has really changed the way I work in areas like popliteal, below the knee, common femoral profunda, things like that. I think it works really well. And then we finished with a DCB, and I'll show you the pictures before
Wow.
and after.
Beautiful.
Yeah, so I think the technology is here. I think we just need to know how to use it. And again, this is early experience. This is something when I did it, I had to go through every step. I think having a great colleagues from surgery to talk to them about it, to have the patient talking to them about it, not pushing one way or the other just because we can, and the patient understanding the risks. Uh,
Yeah, I mean that's an absolutely beautiful result. I mean, obviously, clearly, no need for stenting. Would you have considered stenting it up front? I mean, I think it's a little bit challenging. Now, you don't need to, of course, but sometimes with your initial picture, you start wondering whether or not you could get that type of result by leaving nothing behind. This is fabulous.
Yeah, stenting is on the back end for us. I really try to avoid
Yeah,
doing stenting in the common femoral. Common femoral for me is what we use for our cardiology work most of the time with impellas and TAVR and all the other stuff. And again, she's a young lady. She's in her 60s, so she has at least 25 years to live, if not longer. Um,
right.
but to me, if I end up getting a complication there, as long as I can have the section controlled and no acute limb and everything like that, if I have a complication, I try to get it controlled and then send her for surgery for repair.
Yeah, yeah, and I completely agree with you. I'm not advocating for stenting the common femoral, not at all. but but I'm just saying sometimes you people do think that. I clearly agree that I don't think you should. At least I don't think you should.
All right. So let me pick your brain on this one now. This is a little bit more difficult. When we had this patient, I really had to think about it. And again, I'm sorry, guys. This is my passion. Going to show a lot of radial to peripheral stuff, but there's this utilization. But it's just two cases that we pulled up here. This is a 75-year-old male. Has a history PAD. Had a left external iliac artery and common iliac occlusion at that time, 10 years ago. Had a fem-fem bypass and actually lasted 6 years. And then it failed. So had a redo fem-fem bypass and has been doing well, but more recently he's been having, life-limiting claudication, rather three, worse with the right side. When you look at the ABI, resting ABI was very
Yeah,
abnormal on the right side. CT scan, I do a lot of CTs. I know that's debatable. I just don't like to be blindsided with the iliac disease when I go in.
agreed.
And yeah, and it showed what expected on the, with the iliac, but the common femoral SFA, the reading was a little bit vague. So it basically said occluded SFA versus distal common femoral, you know, Anyway, so let me show you the pictures. So in this situation, really, I need to take pictures, and the plan was take pictures and then plan the next step. And we did an angiogram. Remember, this groin has been accessed twice, two different surgeries. You just mentioned that. Recurrent surgeries usually end up with maybe higher risk of
Yeah,
complication.
higher complication. Yeah, morbidity for sure.
So we go radial, we take pictures, and you can see the fem-fem bypass looks really good,
Yeah.
but it's a common femoral where I don't really see the profunda. I don't know if the profunda is occluded. And so when you look at this, what's your thoughts?
Yeah, no, I mean that's obviously a critical stenosis versus an occlusion of this. It looks like distal common femoral artery. And I agree with you. I don't see the profunda either. Now, given the fact that there was redo surgery there, and there's a fem-fem, and if the fem-fem was completely redone versus one side or not, I think an opportunity to get this patient out of that lifestyle limiting claudication in a minimally invasive manner, I think is completely reasonable. I think the possible complications that could occur from open surgery or redo open surgery in that groin, I think outweigh the benefits from doing this open. So we would try to again take some selective images and see if we can cross and identify the profunda origin, and if we have to do some selective um, angioplasty versus IVL versus something, that's the method that we would start off first.
Perfect. So same thoughts. Again, I think this is something when we say multidisciplinary, I think this is extremely important.
Yeah.
So what we did is the same thing, went radial, and we were able to cross it with the command, but nothing crossed. After the command, I had to use a 2O balloon just to be able to get my microcatheter in.
Now, Sam, let me ask you a question. On the since you got the imaging CT, did you know was the SFA and distal open, or were you going into a blind segment?
Uh, SFA is open.
Okay.
The SFA was open and no disease all the way through to the foot.
Okay, great. Okay,
And the
great.
tube
Okay,
must
good.
have run off. Yeah.
Yeah.
So we had the radial prepped, we had the pedal prepped when we went in, because I think that's where you're alluding to figuring out which pathway I need to get through.
Right.
So we put a wire, we put a Viper wire, and we IVUSed, and then what we end up doing, a orbital atherectomy with a 1.75 burr over a 180 centimeter. There are a couple of CSI Diamondback catheter that's meant for radial. And I think the most important thing on this one is really gotta be careful not to burr around the takeoff of that fem-fem. Because if I really damage that fem-fem, I think the left leg will become an acute leg and then become a bigger issue.
Right.
I was just very important because we found a spot where there's a gap between the common femoral lesion and where the
And
fem-fem
then the
is.
takeoff.
And we kind of
I
marked it and we just tried to kind of not getting through it.
mean, any consideration for just using IVL there, or that's probably before your IVL days?
No, we actually did IVL at this point.
Oh,
Well, actually, let me see. Maybe we didn't. I don't think we did. No, I don't think we did. I think we did
okay.
atherectomy, and then I did a balloon angioplasty, and ended up with a DCB. And at this point, the question is, does angiography sufficient? We put an IVUS in there. You can see a nice crack in the calcium. The lesion looks much better. I still use gradient. I mean, I'm not sure if I'm an old school, but I'm a big fan of gradient in iliac and common femoral. I think add another layer of comfort. And this is just to show before and after. And the mean gradient was at the end was 5 millimeter.
Uh, that's a great. I mean, that's a great result.
So
That's a great result. I mean, I think patients lucky that you were there and such advanced skills. I mean, I can say like, we can do a redo surgery in the groin, but they can be challenging. I think it's important for the non-surgeons to understand. Oh, just redo the groin. I mean, redo groins are tough. They can be tough. Sure, we do those for a living, but there are inherent complications that can occur. And then if you can avoid that and get a result like Sam, like you were able to get here, I mean that's fabulous for the patient.
yeah, I'll tell you, I was smiling when the
Yeah.
I saw the profunda. That was my like highlight when I saw the profunda going
Yeah, that's
through. I
great.
was like, this is what we want to have. So
No,
I
I
think,
mean, like as you bring up, I mean, sure, could you do that open? You could, but I mean, the result you're looking for is a result that you were able to display right there. And so, if you're able to achieve that minimally invasive, I don't think you're out anything. You were able to keep this minimally invasive for this patient again like I said, with a very successful result. So,
yeah, no, again, I think this is where um, it's great to have friends. It's great to have people that you can call and ask. There's no reason, none of this patient are acute leg that you need to do it right there. I think nothing wrong with taking pictures, pause, run with your colleague, friends. I think
right.
uh, all of
Well,
us.
that's the benefit of also having a multi-specialty group. I mean, we're fortunate as well, where you can kind of bounce ideas off each other to make sure that this comes up with the best plan for your patient, even if it's not in your own group. Like you said, colleagues, around the country, around the world, like you and I, we can always bounce ideas off each other and see, hey, what we think is not just going to be successful, because that's important, but what's also important is that you want to have a durable result. You want to come up with a plan so that you're not redoing this all the time. So I think it's very important to have friends.
I'll add one more thing. I think even if you don't have friends, that's one of the things that attract me to MurmurMD. It's like that's your X for vascular and cardiology. So you can put this case and it's like, what do you guys think? You have friends
Yeah.
from all across, from East Coast to West Coast, different subspecialty, bouncing ideas, things that not all of us has all the products. And I think having the MurmurMD platform has really changed many things I do. I just send it there, like, what do you guys think? You can put it even anonymously if you don't want to put your name on it because you want to, some are more like not very comfortable. But I think that's something it's very helpful having a platform for all of us to come together to learn from each other. I want to finish, Nick, with thank you. And I want to really thank you for taking time from your busy schedule. It looks like you are in a beautiful city of Chicago with a beautiful, scenery
It's it,
behind you.
it's pretty nice.
I'm under breath with, but I know you told me you're in a conference. I hope you enjoyed the rest of the conference. I really appreciate taking some of your busy time, and hopefully we can have you again here as a guest in the future podcast.
I'd love to. Sam, first of all, thank you so much. First of all, for bringing awareness for vascular disease and for all the amazing patient care and operations that you do and the care that you do. It was wonderful to be on this platform. I'd love to be back here again. And I think this, cross-specialty collaboration, figuring out what we can do on behalf of the patient and for the disease process, I think is the best way forward. And I look forward to seeing you hopefully soon again.
Thank you.
Thank you.